So I'm going to talk about switching therapy before and during pregnancy, as you have heard. These are my disclosures. I'm going to talk about a 34 years old Spanish lady who was diagnosed with HIV infection approximately 10 years ago. And she moved to the UK 3 years ago. And she was previously seen in a different clinic than the one run by us. And we actually have a transfer of care letter from that clinic that says that in different occasions her viral load was detectable, usually between 150 and 250 copies a ml. She was on tenofovir, on TDF, emtricitabine, and atazanavir-ritonavir. And one of the resistant tests sent on those detectable viral loads amplified and showed to be wild type. So currently, this lady is presented to our clinic. She's still on TDF, FTC, atazanavir-ritonavir. Her viral load is 6,500 copies a ml. Her CD4 count is 321, and she is 14 weeks pregnant. Importantly, she reports morning sickness, and she says she vomits few times a day. So let's just very briefly go through antiretroviral therapy nowadays. This is the number of antiretroviral drugs that have been approved up to the end of last year. And you can see that there are very many, and also very many are combined in single pill combinations. However, when we talk about pregnancy, a lot of them disappeared. And the choice of antiretroviral drug and combinations during pregnancy in women living with HIV is limited, very much limited compared to what non-pregnant people can have. And this is because a lot of antiretroviral drugs are not recommended during pregnancy. And I would like to underline here the importance of study the safety and the pharmacokinetics of antiretroviral drugs during pregnancy, and the importance of including pregnant women in research studies. So, what do we need to know about antiretroviral drugs during pregnancy? We need to understand mainly two things. We need to understand the drug exposure, what we call pharmacokinetics, and this is usually done in 10, 20, 30, sometimes 40 patients. So 40, up to 40 women living with HIV who are pregnant, mainly during the third trimester, sometimes data from the second trimester and postpartum are also important. And the other very important factor that we need to study is teratogenicity. And this is more difficult to study because we need many pregnant women living with HIV that are treated with a certain antiretroviral drug. We need hundreds or thousands of people to understand whether a drug, an antiretroviral drug, causes teratogenicity. So in terms of drug exposure, the reason why it is important to study drug exposure in pregnant women living with HIV is because during pregnancy, there's a number of physiological changes that might alter drug concentrations, such as drug absorption, drug distribution, drug metabolism, and also drug elimination. However, sometimes, even if we measure lower drug concentrations, it doesn't mean that there is less drug at the level of the target, at the level of HIV. So interpreting drug concentrations in pregnant women can be tricky. And in terms of teratogenicity, we know that over the past 2 years, there have been concern about the potential risk of developing neurotubal defects in women conceiving on dolutegravir. I think the data today are much more reassuring than those presented 2 years ago. And at AIDS 2020, data showed that the prevalence of NTDs in women conceiving on dolutegravir is much lower than what was originally thought. So going back to Our Lady, obviously for us, her priority is her virological control as her viral load is detectable. We need to understand her level of adherence. We need to understand if she's vomiting her antiretroviral therapy or whether she can't take it, not because she forgets, but because she's unwell. So they came to me and asked me, do we need to switch her antiretroviral therapy? But if we switch it, what do we switch it to? In her case, it would be probably helpful to give her less pills. But what can we do? What combination can we give her so that we give her less pills? And this is, remember that we are choosing from that limited availability of antiretroviral drugs that can be used in pregnancy. So should we avoid abacavir because of nausea? Should we avoid ritonavir? She's currently on ritonavir. Should we avoid drugs that cause already gastrointestinal symptoms because of what she's experiencing? Should we avoid raltegravir, which in pregnancy can be used only twice a day, but giving her twice a day drugs with her vomiting, frequent vomiting during the day might not help? And also the genetic barrier of raltegravir might not be the best in her situation where she has a history of poor adherence and detectable viral load, and she has a detectable viral load now. What about dolutegravir? So in terms of conception, she's already well after dolutegravir risk for potentially conceiving on dolutegravir. And can we give her dolutegravir so that it is an integrase inhibitor that favors the decay of viral load? It is once a day, it's a small pill, and it might help us to get her undetectable. So when she presents 3 months later, she says that the morning sickness improved, but it never really resolved. So she still has some nausea and vomiting, but much less than earlier in pregnancy. She's still on TDF, FTC, atazanavir, ritonavir, but her viral load is lower, it's 650. And she does still report that sometimes she forgets to take her antiretroviral drugs. We do perform a therapeutic drug monitoring at one point in her pregnancy history, which actually shows a good atazanavir trough concentration. Obviously, if she took atazanavir the day before, it means that there is drug there. It is reassuring to see that if she takes it, there is enough drug there, but it's not really, really useful to assess her adherence pattern because she might just take it the day before she comes to clinic. So I think at this stage, it's really important to focus all our effort to get her to undetectable, to make sure that she has an undetectable viral load at delivery. So dolutegravir is now added to her antiretroviral regimen. And the other option is to make sure that she takes it, and DOT, directly observed treatment near the time of delivery can be useful. The Viva guidelines for pregnant women living with HIV underline the importance of doing as much as we can to make sure that women living with HIV have an undetectable viral load at delivery. Obviously, we need to do TDM if it's useful, a resistant test with a detectable viral load. And again, very important to optimize the regimen with drugs that readily cross the placenta, like double dose tenofovir, raltegravir, and I would add dolutegravir to this list. Recent publications on the safety and pharmacokinetics of dolutegravir in pregnant mothers with HIV infection and their neonates are now available, and they underline the importance of using dolutegravir, especially at the end of pregnancy in women with a detectable viral load, in order again to make sure that the viral load decay occurs and the viral load is undetectable at delivery. And then we must not forget the management of the newborn, because if our lady had a detectable viral load for the majority of her pregnancy, we need to make sure that we evaluate the risk of the baby to be infected with HIV. And if the baby is at high risk, like the baby in this case, we need to make sure that they receive appropriate treatment. So in conclusion, Miss CR delivered at week 33, so quite early. She had a viral load of 250 copies ml at delivery, and she was on 4 drugs when she delivered. And again, in this case, the infant is at high risk. However, it was a early born baby, hence it might be able to only receive AZT intravenously at the beginning, because it wouldn't absorb oral treatments. It is really important to manage these cases as a multidisciplinary team with the pediatrician and the experts on pregnancy. And obviously, it is also important to discuss breastfeeding and the importance of having an undetectable viral load if the woman wants to breastfeed. Otherwise, avoid breastfeeding, and also discuss the risks around breastfeeding in women who have an undetectable viral load. Thank you very much for your attention.